Yes, we thank Professor Bob Anderson for his contribution from the bottom of our hearts. Really, it's the great expert, especially in the anatomy of the heart.
Okay. Good morning, everybody. Good morning, everybody. I would like to present the next speaker, who is Dr. Germanakis. He's a professor of pediatrics and pediatric cardiology in Crete, in the University of Crete. His talk today is going to be clinical presentation of pulmonary valve stenosis, regurgitation, and RVOT obstruction. I think this is a recorded session, right?
Yes, please.
Good morning.
Dear colleagues, dear ladies and gentlemen, I would like to thank the President and the Organizatory Committee of the International Congress of the Balkan Society of Pediatric and Congenital Heart Disease Society for the honorary invitation to participate into this presentation. Congratulations for the initiative, and I will be honored and very glad to actively participate in this new effort of cooperation between the Balkan Pediatric Cardiology colleagues. This is the title of this presentation is Clinical Presentation of Pulmonary Valve Stenosis, Regurgitation, and RVOT Obstruction. There are no conflict of interest, and as discussed, we are glad to cooperate and to assist by all means in this fantastic project and idea. Crete is the southeast part of Europe and of the Balkan countries, and we have the smallest and the southeast pediatric cardiology unit. So we are very glad having cooperation with all means. The topic is clinical presentation of a specific heart lesion. We have to remember that clinical presentation regards the evaluation of patients lying on a bed. Klini is the ancient Greek word for bed. The modern term is krevati, and this is the terms of the bed in several languages. The clinical, therefore, evaluation of patients, the physical evaluations, regards the detection and the documentations of any symptoms, and a careful physical evaluation consisting of inspection, auscultation, and palpation. The anatomy is the one which can explain the symptoms and the physical findings. In cases of a narrowing of the pulmonary valve, and if it's accompanied by ventricular septal defect, as in the case of tetralogy of Fallot, the clinical presentation depends on the predominant lesion, if it's a pulmonary stenosis or if it's a large ventricular septal defect. Therefore, the forms of severe right ventricular obstruction will end up in a diminished lung perfusion, and to the Greek term kyanosis or cyanosis, which can be associated with increase of the red blood cell mass, polycythemia, and the corresponding known central cyanosis. Neonates with severe reduction of pulmonary blood flow, they will end up being severely cyanotic, and their cyanosis won't respond in oxygen administration. In cases that there is an associated ventricular septal defect, depending on the size of the defect and the stenosis, babies can be red, not cyanotic, and as the subpulmonary valve narrowing progresses, they can develop cyanosis and the typical dead spells described in the literature. Luckily, we don't see it so often. A very important clinical recommendation for detection of congenital heart disease has to do with the implementation of neonatal saturation, transcutaneous saturation measurement and screening. And this is mandatory that all neonates before discharge, they will get a saturation measurement which has to be more than 95% according to the most recent update of these guidelines. The cardiac auscultation remains in our days the main means of detecting heart abnormalities, structural abnormalities, provided only that it's performed correctly. The explanation of the heart murmurs is simply the presence of high velocity flow associated with vortex, we call it turbulent flow, and the mechanical energy of this flow transmission to the thorax, which can be detected with a stethoscope. Auscultation is older than the stethoscopes. It was performed by direct placement of the head on the chest. We are grateful to Laennec, the founder of the stethoscope, which had the idea of rolling a piece of paper and listening at a patient's chest. That's the way it started. People are asking, and the young trainees in pediatric cardiology or the pediatricians, what kind of stethoscope they should use to perform pediatric or neonatology cardiac auscultation. Of course, the thorax of the child makes some limitation, but it depends on what you're looking for. It is very important to understand that a stethoscope is a sound transmission instrument greatly affected if you choose the diaphragm to detect high frequency sounds or the bell to detect bass low frequency sounds. The smaller the diameter of your stethoscope, of your bell or diaphragm, the higher the frequency it can detect. So small size stethoscope can detect only high frequency sounds. Therefore, neonatologists commonly are panicked and will call you because they have heard high frequency sound as this one, corresponding to small ventricular septal defects or pulmonary peripheral pulmonary artery stenosis. They can easily detect them and they are worried and they can call you for evaluation. A systemic approach in the auscultation of the pulmonary stenosis and associated lesions follows the general methodology. We have to check if it is rhythmic or not, if the heart sounds, the first and the second heart tone are normal, and if we have abnormal cardiac sounds. The normal cardiac sounds, this is a artificial simulation, consist of the first, the closure of the AV valves, and the second, the closure of the arterial valves. It's very important to detect them correctly and to define systole as the interval between the two of them. Diastole starts after the second heart sound. So it's very important to classify your murmurs as systolic, diastolic based on that. In the systole, we have the blood flow ejection, and in the diastole, we have the feeling of the ventricles. Although we give emphasis in murmurs, the evaluation of the heart sounds is of paramount importance. So, for example, in case that second heart tone, the S2, is always double, like in this example, and not only in inspiration, which is normal, we speak for a wide fixed split second heart tone. A wide fixed split second heart tone in the presence of a systolic murmur like here. A systolic murmur in the pulmonary area, therefore, followed by a wide S2 fixed split, it speaks for an atrial septal defect and a volume overload of your right ventricle. It does not speak for pulmonary valve stenosis. In addition, if the first heard sound which is always single, sounds double, like this, in this case, probably it's not a double S1, but an early systolic click following the first heart sound. And this speaks for a valvar stenosis, and the early systolic click, it's the opening snap, the opening sound of a stenotic valve. Here it's an aortic valve. The same is the case for a pulmonary valve. So following the evaluation of the first and the second heart sound, then we have to differentiate systolic murmurs typical for pulmonary valve stenosis from the most common innocent accidental or Still's murmur that we find in pediatric practice. Here we can hear a still murmur. We call it systolic vibration, and here it's an abnormal high flow murmur through a stenotic pulmonary valve. So the systolic murmur of pulmonary valve stenosis, they are systolic. They are systolic because the valve does not open completely. The same is the case if you have a subvalvar or supravalvar stenosis. The murmur has a typical diamond-shaped, we call it crescendo decrescendo. Here we hear one ejection murmur. And as discussed, if there is a valvar stenosis at the level of the valve, like here, then the murmur will be preceded by an early systolic click. It is very important to differentiate if we hear an ejection murmur high between a pulmonary valve stenosis and aortic valve stenosis. It's difficult sometimes. The pulmonary valve stenosis is best heard on the left, while the murmur intensifies when we breathe in inspiration as we have an increased blood flow through the pulmonary valve. In addition, the pulmonary valve stenosis radiates to the axilla or to the back, in contrast with the aorta that radiates to your fossa jugularis. A diastolic murmur can be heard if your pulmonary valve won't close completely. It will start immediately after the second heart tone. It will be decrescendo, the intensity will decrease, and at times it has high frequency. Special care has to be paid when we're listening at two heart murmurs, a systolic and a diastolic, like in this example. And to differentiate it from a continuous murmur, because if you have a systolic and a diastolic murmur over your pulmonary valve, it means the valve is not opening and it's not closing, so it has stenosis and regurgitation at the same time, and we have to differentiate these two sounds from a continuous murmur. In the case of pulmonary stenosis, atresia, operated tetralogy of Fallot that they have conduits or PDA, then a continuous murmur can be heard. The presence of a loud continuous murmur with a relative good saturation speaks for a good and wide open BT shunt. The clinical evaluation of your patients adds additional information into your echocardiographic findings. Here we are listening again the continuous murmur of a ductus, and we see a ductus arteriosus. Cardiac auscultation, therefore, in modern times, in modern era, is still useful. The question, is it too old to rock and roll or too young to die, can be answered only if one knows what we're talking about. People who never perform and do not know to perform a clinical or a physical evaluation cannot really understand the meaning of this technique and the additional information it offers. In our days, that almost all the severe fetal congenital heart disease are diagnosed prenatally, we are happy for that, and we can be prepared. Nevertheless, there are cases that escape the prenatal diagnosis, even severe of them, and the clinical indication of measurement the saturation of these babies and appropriate giving them prostaglandins and transferring them is a knowledge that we have to continue to keep. And also, as the epidemiology changes and the more severe forms of congenital heart disease won't be born, milder forms like pulmonary valve stenosis, their detection will be based on clinical evaluation performed by the general physician and the pediatrician. In conclusion, pediatric cardiac auscultation remains a first-line clinical tool, provided that doctors have spent some time and the medical students to learn it. As Hippocrates said, teaching and learning of medicine and the art of medicine needs time, needs effort, and it's not easy. In the faculty, in the medical school of University Hospital of Crete and Crete, we are very happy, and we have make a considerable investment in teaching, among others, cardiac auscultation and echocardiography. From sound to ultrasound was some Erasmus programs provided many years ago with the cooperation of several universities. We have developed an open e-learning material that students and doctors can listen to several types of congenital heart disease sounds, and we incorporate these teaching programs into programs regarding pre-participation screening in children. In the last organization, 2024, we were very happy to have also doctors from the Balkan countries and medical students. We would be very happy to continue this cooperation also under the auspices of this new beautiful society. Thank you for your attention. I'm looking forward for our cooperation. I regret I could not be with physical presence there today, but I hope that we have the chance meeting us in the near future. So, good success to the Balkan Society of Pediatric and Congenital Heart Diseases. Congratulations. Thank you very much. I am very honored and very happy to be invited in this initiative. Thank you so much.
Thank you very much, Dr. Germanakis, for this very didactic presentation. We have also some registered medical students, and I guess your presentation would be very useful to them. Thank you very much. The discussion will be at the end of the session.